Friends, on occasion of completing 25 years of SISA services, we have organized this 14th SISA Live Surgery Conference. I am Dr. RaghuveerReddy, Organizing Secretary. I am joined by Professor Adrian Wilson from UK, Dr. Christian Kell from Germany, and 20 skilled surgeons from India who have participated in our discussions on advanced surgical methods. A major focus of our dialogue has been on preservation of the knee joint, stressing the importance of repairing rather than replacing it, especially for our younger and more active patients. We have highlighted the procedures like high tibia osteotomy, which aims to prolong the life of the partially damaged knee and potentially avoid the need of joint replacement. This conference has brought together over 400 orthopedic surgeons from across India to explore the advanced knee techniques in the re-element surgery and related areas. So this conference is being done in association with London Osteotomy Group and with the 20 national faculty. So before going to the surgery topic, we'll go to some basics. So we want to make you some little bit first year anatomy of the students. So what we see in the X-ray, it is bone. What we don't see, it is joints. So bone has got a healing capacity. So if you sustain a fracture, what we do, we put a plaster, plate or screws. On the villages, they do coax treatment. Within 3 months, it will heal. Whereas joint injury doesn't happen with major accident. It happens with mild injury, twisting episodes. Swelling will be there for 1 or 2 months. Afterwards, it will settle. But patient will remain disabled. You can do routine sedentary things, but he won't be doing demanding things. So this is the bone, upper end is covered by cartilage. This is the meniscus, acts like a shock absorption in two bones, and this is the ligament. So ligaments, meniscus, and whole joint is surrounded by a capsule. If any fluid accumulates, the joint will swell. So fracture, it will heal. And to see joint, we have two options. One is MRI and arthroscopy. And this is how the cartilage looks on the screen. So soft, viscoelastic. So normally cartilage wear starts from aging physiological 30, and it is by 70, 80 it gets worn off. But in some stages it gets early. It may be because of injury, overuse, overweight, even genetic. Even thin people also can get arthritis. So we stage mild, moderate, and severe. And these are various surgical methods, non-surgical methods. And these are surgical methods. So what we are going to talk is joint realignment procedures. What is the other end is a replacement. In between we have a ligament, meniscus, cartilage surgery. Even for that, realignment is required. So if the knee is completely damaged, cartilage, then we do total knee replacement. If it is partial knee replacement. So these replacements, they last for 20-25 years. So if patient comes, age between 40 to 55, so they'll tell, doctor, you're saying replacement after 60, 65, but I'm now 40, 55 in between. What to do for next 10 years? Because I'm a breadwinner, I have to be active. That comes the realignment joint preservation concept. So normally the weight bearing axis starts from center of hip to the center of knee to ankle. Here in early cases the axis changes. So in high tibial osteotomy we cut the bone surgically to straighten it so that some portion of the body weight from the worn out portion of the joint is transferred to the healthier part, thereby redistributing the forces, thereby pain comes down and function is improved. This is the correction alignment, and we can have a fibrous cartilage growth. This first why we plan this and do a fixation. So these are ideal candidates, usually recommended for mild to moderate arthritis, especially those under 55 years of age, as well as athletes and active older patients. Recovery after osteotomy typically takes 6 to 12 weeks, and most of the individuals they go back to resume normal activities within 6 months and sports within 12 months. So these advanced surgical techniques, they have got potential to delay or you can avoid the joint replacement surgery by maintaining the natural knee function. So it is like two things. It can be a stopgap before joint replacement, and sometimes you can avoid it. So what it means is, even if you get 10 to 15 years life, it is good major benefit to the patient. So there are indications. Every indications there the patients are there. Some patients they require TKR, some they require partial, some they require HTO. Normally in our society, only they say only PRP or joint replacement. So we are talking about joint preservation. So we have two examples. This patient, you can see the lady, 42 years female, joint is, you can see axis is going here, not in the center. So we did a alignment correction. You see here how she was walking before, 6 weeks later. If you would have left for at least another 5 years, she would have gone for joint replacement. She would have become grandmother. So another case, 60 years male, teacher and farmer. You can see it's bone on bone. So he requires actually ideally joint replacement. But he says, doctor, I want to work. If I do joint replacement, he can't go and do farming. He does farming himself. So you see the axis is going here. So what I did is, I did a realignment surgery. I told him to go for second leg after 2 months, but he has come after 2 years. Some more joint has damaged. So I have to do at higher degree, 2 level surgeries. Now he can do farming for another 10 years. So this is the thing what I want to show about joint preservation, and we'll talk about 2-3 patients, then we'll have a question and answer session. Madam. Madam is, you can stand. Just stand and move. Your age ఎంత 64. మనం సర్జరీ చేసి ఎన్నాళ్ళు ఏంటండి 2.5 years. ఇక్కడికి వచ్చాను, జస్ట్ వాక్ మాట్లాడండి. So she underwent joint preservation surgery, realignment, 2.5 years back. Me just can talk what you felt, what is the pain relief. తెలుగులో మాట్లాడచ్చు.
అంతకుముందు నాకు ఆపరేషన్ చేయకముందు చాలా నొప్పి చాలా ఎక్కువ ఉండేది. 2-3 సార్లు డాక్టర్ చూపించిన తగ్గల. తర్వాత ఈ డాక్టర్ గారి దగ్గరికి వచ్చిన తర్వాత వెంటనే సర్జరీ చేద్దామన్నారు. చేసిన తర్వాత చాలా రిలీఫ్ ఇచ్చింది.
మీకు రిప్లేస్మెంట్ మీకు ఫస్ట్ అడిగారు కదా, రిప్లేస్మెంట్ కానీ మనం రిప్లేస్మెంట్ చేయలేదు. ఓకే, కానీ మీరు ఇప్పుడు అన్ని పనులు చేస్తున్నారు కదా, యోగా నేను చేస్తున్నాను అని చేయగలుగుతారు. నార్మల్లీ జాయింట్ రిప్లేస్మెంట్ చేస్తే ఇంత యాక్టివ్గా ఉండలేరు. So this is the person I was talking. He was doing farming. Me experience చెప్పండి. How whatever you want.
ఫస్ట్ చాలా కాళ్ళు చాలా బెండ్ అయిపోయింది బాగా. ప్లస్ బ్యాక్ పెయిన్ కూడా బాగుండేది. నేను ఫస్ట్ డాక్టర్ దగ్గరికి వచ్చినప్పుడు ఈ నీ రీప్లేస్మెంట్ చేయమని చెప్పొచ్చాను. అయితే అది చేయించుకుంటే అంత యాక్టివ్గా ఉండరు, మళ్ళీ ఎక్కువ టైము దానికి వాల్యూ ఉండదని చెప్పేసి ఈ హెచ్టిఓ చేస్తే చాలా ఉపయోగం మీకు. 10-15 ఇయర్స్ వరకు మీరు చాలా యాక్టివ్గా ఉంటారు అని దాని గురించి వివరించి చెప్పడం వల్ల నేను ఫస్ట్ 1 లెగ్ చేయించుకున్నాను. చాలా పెయిన్ రిలీఫ్ అయ్యింది. దెన్ మళ్ళీ 1 ఇయర్ తర్వాత మళ్ళీ నెక్స్ట్ ఇంకో లెగ్ కూడా చేయించుకున్నాను. ఇప్పుడు 2 లెగ్స్ చేయించుకున్నాను. చాలా బాగుంది. యాక్టివ్గా ఏ పని అయితే ఆ పని చేసుకోవచ్చు. యాక్చువల్గా ఫార్మర్ అగ్రికల్చర్ కూడా చేయిస్తున్నాను నేను.
అట్లే కూర్చుంటావా?
కూర్చుంటాను. అయితే కింద కూర్చున్నాను.
కూర్చొని లేవాలి.
జాయింట్ రిప్లేస్మెంట్ ఇవన్నీ చేయలేడు. యూ కెన్ స్క్వాట్, యూ కెన్ స్విట్.
చాలా బెండ్ ఉన్నాయి. 2 కాళ్ళు ఇట్లా ఇట్లా కింది ఇట్లా బెండ్ ఉంటాయి. ఇట్లా స్ట్రైట్గా ఉంది. అసలు ఇట్లా లేకుండా
మీరు ఫోటో చూస్తారు ఇదేనే.
ఉన్నది.
So you want the lecture that you presented with escape?
Yeah.
Was before.
Yeah.
స్ట్రైట్ ఉండకపోయేది. చాలా
Yeah, you can see him now how he's walking. Cross. See, before. Now how he's walking. Same person.
అంత అవసరం ఉండదు.
Thank you. షటిల్ మీ ఏజ్ ఎంత అండి? 4. ముందుకు వచ్చాను. 54 years. So he wanted to play for another 10 to 15 years.
Actually, I used to play since 10 years to shuttle badminton. Suddenly, I unable to walk single step also. I unable to steps or climbing steps and falling steps also. Then sir suggested to do this HTO surgery. This is you can 10 years you can it gives life. Sir told. That's why I say yes. Now I am able to walk and I am since last month I started to play shuttle badminton. That is my favorite sport.
How many months after the surgery now?
Surgery I underwent surgery in June 23. June 13, 2023. He is playing now. Now I am playing. Thanks to RaghuveerReddy sir. Okay. Thanks to you.
Thank you. Now, see, basic questions also you can ask. Because they are the designers of the plates, these are designers.
I mean, just before anyone thinks of a question to ask us, it's interesting because in many countries, similar events like this have taken place where somebody has presented this concept of joint preservation where patients either are told there's nothing or it's a knee replacement and they just don't want that and they're young. I can think of one example in Japan, a friend, more a Christian than myself, a very famous professor, actually went on national TV. It was a very popular time of the day, so it was seen by a lot of people. And overnight, osteotomy went like this. So there was a very small number of patients who were receiving an osteotomy, and now it's become a very common treatment in Japan for the management of arthritis on the inside of the knee. And this has taken place in many different countries, but that was an example that I think was most dramatic in terms of what we've seen in the last decade or so.
You can take mic and ask questions.
Again, just to, once we fill down the most reported newspaper in the UK, the one that most people read is the Daily Mail. It's not the most intellectual newspaper, but it's the most popular. And one of our friends, Matt Dawson, he had an article showing that only a very small percentage still of patients in the UK are receiving this joint preservation surgery, and they're just not being offered it. And they're being offered nothing, or they're being offered a knee replacement. And actually there's some very, very good evidence to show that knee replacements in active people don't last very long. So in a sedentary 65-year-old, a knee replacement can last forever. But in an active 55-year-old, the knee replacement can fail. And the statistics from the UK, where they have massive data sets, show early failure in a very high proportion. As much as a third will fail within 4 years. So if you do a knee replacement in somebody that wants to play badminton, the chances are he has a 1/3 chance of it failing within 4 years, and then it's a big problem because now it's another knee replacement.
Probably he will not come back to badminton. You had a question?
Yeah, so I just wanted to check, what's the age group of people, and is it common for people under 30 also?
So being osteoarthritis, undergoing
Yeah.
either total knee arthroplasty or eventually alternative treatments.
Yes.
So there is a common age group where you obviously have a knee osteoarthritis, which would generally be applicable for arthroplasty, and usually the knee osteoarthritis kicks in a bit later than hip osteoarthritis. So we are talking about patients in their 5th or 6th decade of lifetime, and so this is a typical age where you would have a worn-out knee joint, meaning a full thickness defect. The patients we talk about generally are probably a bit younger, being like 40 or 50. And the purpose of this surgery is actually to prolong the period where you don't have to undergo joint replacement surgery. Because joint replacement obviously is a definitive step. It's something where you burn bridges, and osteotomy about the knee, which is the limb alignment correction, which would enable you to follow a normal lifestyle and actually go back to activities of normal daily activities that would enable you to have a higher quality of life. These surgeries actually are there to achieve this for a longer period of time and prolong the period where you potentially go for arthroplasty, or maybe delay it to a point where you never have to undergo arthroplasty.
So one of the problems with the joint replacement or joint arthroplasty is happiness. So if you look at all surgeons in each of the countries, whether it's the US, the UK, India, wherever, and you look at how happy they are, you have 10% of patients absolutely delighted with their total knee replacement. And you have 70% of patients say, do you know what, it's better. And my pain isn't here, my pain is there. It clicks, it doesn't feel completely normal, but I'll have the other one done when it needs doing. And then there is a 20 to 30% failure rate, where the patients think it's worse a bit or a lot. And often you have no cure for this. Unless you can identify a problem, they have an infection or they have some sort of misalignment, which is quite unusual. So in the UK, we know the statistics well, there's 100,000 knee replacements, 10,000 happy patients, 70,000 very happy patients, 70,000 happy patients, 20 to 30,000 patients unhappy, a bit or a lot. If you look at osteotomy, the success rate is extremely high, and it can remain like that for 10 to 20 years. There's good data for that. So in terms of the operations that we do, if you do a total knee replacement, a partial knee replacement, an ACL reconstruction, complex cartilage, meniscus surgery, osteotomy, if you take all of the operations in knee surgery, the one that gives the highest level of satisfaction is osteotomy, which is amazing. And if you take the Indian subpopulation globally, because Indians tend to have quite a lot of bowing, the proportion of people that are suitable for this is much higher than it is in the Northern Hemisphere.
And Professor Adrian was talking about Japanese people. The incidence is increasing osteotomy. Why? Because in Japan, their lifespan is around 9,500. So they try to preserve the joints up to 70, 75. So they go all for osteotomies and they get replacements after 65 and 70. And the implant will last for another 20 years. Here what happens, in other countries, because of marketing and all those things, people are getting attracted for joint replacements and they are getting done at much early age and they are not satisfied.
Yeah, and don't get us wrong, we like joint replacements. We do a lot of joint replacements. So yesterday we did a partial knee replacement with Raghuveer on a patient who was an ideal candidate for a partial knee replacement. So we do lots of totals, lots of partials, but we also do a lot of osteotomy where it's indicated.
Yes, the task is just to find the right treatment for the right patient, and as a reflex right now, what we see due to marketing and other aspects, actually patients are being pushed into this corner of undergoing joint replacement surgery rather than preserving their joints. And I mean, we have 3 examples here of happy patients that have undergone joint preservation surgery and are still happy with their knee joints. So, I mean, this is the best example that there is an alternative for replacement, and we just have to bring it out to the people, because as we alluded to at the beginning, most of the people around just don't know about the opportunity that there is alternative treatment pathways.
And the osteotomy thing is a bit of a renaissance that started very early, relatively speaking, in Central Europe. So in around 2000, the Central Europeans, the Germans, and the Dutch, and not the UK, were doing a lot of very good osteotomy work. And then we actually came together as a group and we started some courses in the UK. When we were very basic and we really were just getting to understand the operation. In about 2006, we ran our first course in the UK. We ran them every year and we had small numbers, and then they grew. And then we were invited by Raghuveer and his esteemed group of knee colleagues that really are the academic chaps in India. And there's about 20 leading knee surgeons in India who attend these courses on a regular basis. We come a lot to India, we see the same faces. There's a circuit and there's 20, 25 guys. And they've started these courses now in India for about 10 years. And now we can see these guys have become masters and experts. So in India now, you have experts in osteotomy like Raghuveer in each of the major cities because they've adopted these ideas from the Europeans, from the Central Europeans to me, and now to India. And actually, it's amazing. In the US, this hasn't actually happened yet. So now we're starting to run courses in the US where they've been so forced away from these joint preservation techniques into joint replacement. It's embryonic and very basic in the US at the moment in terms of how much osteotomy goes on. So that will be another place where we'll see an explosion of osteotomy, which is now currently happening.
So you mentioned about
So what we do is we follow our patients and we ask them a series of questions. How much pain are you in? How far can you walk? What about climbing stairs? And it looks into the quality of life in terms of activity. And then we do a surgery and then we see how the patient responds to that. And in terms of returning to high levels of activity, osteotomy has one of the highest levels of success. So 90% of patients will get back to their pre-surgery level of activity before their pain kicked in. If you're an elite runner, and over I can think of an example, we did together a guy that running was his life. He was a banker, he was mid-50s, bone-on-bone arthritis, and one day he stops being able to run. And then it's painful to walk, and he comes to see us, and we straighten both his legs up. And he didn't want it for walking, he wanted it for running. And the guy then sends us a picture 8 months, 9 months later. He's competed in Florida in a 5K run, and he came first for his age. And he came, there were 400 people competing. It was a very competitive event. And he came something like 12th overall. He was 55, this guy. And he had bone-on-bone arthritis. Now, in the States, he'd have been offered a total knee replacement. He wouldn't have even been offered a partial. And in India now, this guy would, in the right centers, would definitely be getting an osteotomy. So the success rate is high 80s, low 90s. It's as good as it gets in knee surgery for happiness and return to activity.
Regarding adding to it, every surgery has got is selection. For example, the patient is a very sedentary man, rich man, gets up, goes in the car and goes to the shop and comes back and sleep. If you're having arthritis, even if you do a joint replacement is fine. But if we do a high joint preservation, he won't feel any benefit. So the patient selection is important. He should be arthritic and he should be active. He wants to be doing active walking for daily 2-3 kilometers. He wants to have 10 to 15 years of active life. Those are the ideal cases. If he is very sedentary, bad arthritis, he can go for replacement.
And also, what happens is that as you get more skilled, we did a case together, Mrs. Beth, and she had a leg that was bent 35 degrees because of a fracture. 30, 40 years ago, she was in a car accident, so her leg has been pointing at a funny angle, and she's now developed terrible arthritis in her ankle and terrible arthritis in her knee. So we talked about it, and we did an osteotomy where she'd fractured in the shin bone and fixed it with a long plate. And at the same time, we did a knee replacement because that's what her knee needed. And 3 months after the surgery, just recently, I saw her. She's bending, she's straightening, she's walking very well for the first time in years. The osteotomy is completely healed, and we have an incredibly happy patient. So even in a relatively sedentary individual, there are times where you can then do these cases, sometimes more complex cases. And as you get more skilled, you start to take on these more interesting and difficult cases. But Raghuveer is right. I mean, it's the young active or the active individual with arthritis that benefits the most.
And active older patients also. That's like 64 years lady. I'm saying younger patients, active patients, and active older patients.
I guess this all refers to a biological age rather than than a calendaric age, where you just look at date of birth. So obviously patients are different there, and when you have an active patient and you see that the patient wants to return to high activity levels, then in some cases an osteotomy is the right answer and not joint replacement surgery. Questions?
Have you understood completely?
Great. Yeah. So I guess the message is quite clear that we want to spread. So there is joint replacement surgeries, and for the right patient, this is the ideal scenario, and you just have to undergo it. And as Adrian said, lots of these patients will be very, very happy, and it's just what they need. For some of those patients, a second thought is worth looking into, and some of these patients would be better off with alternative treatments that just have to be around and actually promoted for these patients so that they know that there is an alternative. And right now, we sadly see that there is a lack of knowledge regards those alternative pathways. So this is now your task to spread the news and actually bring it out to the people that there is interesting alternatives that one has to consider when being indicated for joint arthroplasty. Not necessarily that you have to change to joint preservation surgery, but some of these patients would. And for them, it's obviously beneficial to just step into a joint replacement surgery at a later stage of their lives, because these surgeries, as Professor Wilson mentioned, often come with a risk portfolio in itself, which is higher than a joint preservation surgery.
Because only the media can educate the public in larger scale. If you understand well, and if you educate the public, then public awareness is created. And what is happening here in most of the Indian cities, either it is PRP or replacement.
Yeah.
You can comment on PRP. Later it's plasma.
So there's also been some great innovation in biological injections. So you can harness the biology of the body. So you can have a 3-day-old baby who breaks their femur and it heals in a matter of hours or days. And you can have a 100-year-old individual who breaks their thigh bone and it heals, but it takes several months, 3 months. But the elderly person still has this healing potential. We all do. So we can take the blood and we can spin it in a centrifuge.
Here they are dealing with both states.
Yeah. So you can take the blood and you can extract the cells and have the plasma, which is rich in platelets. And in early arthritis, this can be very effective as a treatment. But as the patient gets older, these PRP injections don't tend to give anything other than very short-term benefit. So as an opportunity to think about what you want to do next, maybe it has a role. But usually in advanced arthritis, these are just temporizing measures, these injections. And really, it's sometimes better just to face up to the problem and get it sorted so you can then have a better quality of life for a longer period of time.
Any more questions? Mr. Ashok, can you come from here? He is not, just come here. He is the boxing national coach. He is suffering from arthritis. He is bowing leg, but he is not interested in the surgery. But his brace, you are wearing the brace? Normally, he uses the offloading brace. He uses the braces and manages.
Which is great. So a brace is a good way of simulating the result of an osteotomy. Sadly, there is not a good compliance in patients with these offloading braces to wear them for very long, because these braces are kind of bulky and they are not very comfy when it comes to sports activities. So this is why patients tend to wear them initially, see that there is a benefit, but then simply forget about these braces or just don't wear them anymore. So for those patients that actually benefit, as we are able to sort of simulate the result of an osteotomy, these patients are actually great. So if we want to convince somebody for an osteotomy, as you obviously say, well, why should I allow my surgeon to break my leg? Well, you should allow it because the simulation of the osteotomy showed great success. And then you don't have to wear the brace anymore.
If he wears the brace only, he can walk properly.
Perfect.
If he doesn't wear, he can't go for morning walk.
Yeah. So
brace is doing
probably is a good
what osteotomy is doing.
good decision guideline and helper in this scenario.
And also the technique was it's quite a frightening concept to have somebody cut the bone and straighten the leg and fix it with a plate. But actually the techniques have improved so much over the last 10, 15 years, all of which we see being adopted in India at the highest level in terms of the small incisions, the preservation of the soft tissues, the minimalistic approach to the actual surgery. Before we used to make enormous incisions so we could see things more clearly. Now it's much less invasive. And with the stability of these modern plates that we now have, often our patients report 2 out of 10, where 10 is very bad pain and 0 is nothing. Often our patients have 2 out of 10 pain the day after surgery and the next days as they recover from this operation. It does take time, but it's not unusual for patients to come in at 6 weeks walking fairly normally, often without their crutches after a simple high-level osteotomy. And that's because of the technique, the anesthetic, the blocks that we put in at the time of surgery, the cryotherapy, the ice machines and so on. So we've really changed this operation so people can recover from it much more quickly. So the take-home message is the best operation.
మా సీసా హాస్పిటల్ 25 సంవత్సరాల సేవలు పూర్తి చేసిన సందర్భంగా ఈ లైఫ్ సర్జరీ కాన్ఫరెన్స్ని ఏర్పాటు చేయడం జరిగింది. ఇది మా 14వ కాన్ఫరెన్స్ కూడా. మోకాలు కీలు రక్షణ పైనే ప్రధానంగా చర్చ జరిగింది. నేను యూకే నుండి డాక్టర్ ఏడ్రియన్ విల్సన్, జర్మనీకి చెందిన క్రిస్టియన్ క్లే, ఇంకా 20 మంది నేషనల్ ఫ్యాకల్టీ, 400 పైగా ఆర్థోపెడిక్ సర్జన్స్, మోకాలు కీలు రీఎలిమెంట్ సర్జరీ మరియు ఇతర సంబంధించిన రంగాల్లో శస్త్రచికిత్స తగిన చర్చల్లో పాల్గొన్నారు. మోకాలు కీలు సంరక్షణపైనే ప్రధానంగా చర్చ జరిగింది. దానికి రిప్లేస్మెంట్ కంటే రిపేర్ చేయడానికి ఒక ప్రాధాన్యతను నొక్కి చెప్పడం జరిగింది. ముఖ్యంగా యువ రోగులు మరియు యాక్టివ్గా ఉన్న రోగుల విషయంలో పాక్షికంగా దెబ్బతిన్న మోకాలి కీలు ఒక జీవితకాలాన్ని పెంచడం మరియు పూర్తి మోకాలు మార్పిడి అవసరాన్ని ఆలస్యం చేయడం లేదా నివారించడం లక్ష్యం గల హైటిబల్ ఆస్టోటమీ అంటే HTO వంటి విధానంపైనే మేము ప్రధానంగా దృష్టి పెట్టాము. HTO అనేది కాలుని నిటారుగా చేయడానికి మోకాలు కీలు కింద ఉన్న షిన్ ఎముకని శస్త్రచికిత్స ద్వారా కట్ చేసే విధానం. ఇది మోకాలు యొక్క అరిగిపోయిన భాగం నుండి కొంత శరీర బరువుని ఆరోగ్యకరమైన భాగానికి బదిలీ చేస్తుంది. దీనివల్ల బరువు సమానంగా పంపిణీ అవుతుంది, తద్వారా నొప్పి తగ్గి పనితీరు ఫంక్షన్ ఇంప్రూవ్ అవుతుంది. ఇది సాధారణంగా మీడియం దశలో ఆర్థరైటిస్ ఉన్న వ్యక్తులకు, ముఖ్యంగా 55 ఏళ్ల లోపు వయసు వారికి, అలాగే అథ్లెట్స్ మరియు యాక్టివ్గా ఉన్న హృదయ రోగులకు సిఫారసు చేయబడుతుంది. ఆస్టోటమీ తర్వాత కోలుకోవటానికి సాధారణంగా 6 నుంచి 12 వారాల సమయం పడుతుంది. చాలామంది వ్యక్తులు 6 నెలల లోపు సాధారణ కార్యక్రమాలు ఇంకా 12 నెలల లోపు ఆటలు తిరిగి ప్రారంభించగలుగుతారు.
మీ పేరు చెప్పు.
నేను డాక్టర్ రఘువీర్ రెడ్డి, ఆర్గనైజింగ్ సెక్రటరీ.
ఓకే.
It is. We should just say osteotomy. The newspapers.
Perfect. Thank you so much.
Thank you.
guys.